This podcast is meant to provide information on reproductive health. It does not establish a physician-patient relationship, and we would urge you to contact your treating provider regarding your care.
One of the most common questions I get is, when should I see a fertility specialist? Well, if you are 34 years or younger and you've been trying for a year or longer to get pregnant, you do have the diagnosis of infertility. If you're 35 years or older and you've been trying for 6 months or longer to get pregnant, you do have a diagnosis for infertility and should go see a fertility specialist. However, I'm here to tell you that you probably don't have to wait that long. There are lots of patients that come and see me. They just want to know where they are and just to get a good idea as to where they should be in terms of their reproductive health. There are other people that don't have to wait 6 months to a year. For example, if you've had your tubes tied or if you've had a previous vasectomy, you know you're going to need a fertility specialist helping you to get pregnant. If you have irregular cycles, meaning you do not ovulate every month, you need to see the fertility specialist from day one. If you are a member of the LGBTQIA+ community, you will need the help of a fertility specialist. So that being said, you don't have to wait 6 months to 12 months to see a fertility specialist. You can decide, I just want to do testing now just to figure out where I am and what my reproductive health is like today. Now we're going to talk about reproductive tract. So I have my book here, the Fertility Manual, and in the book there is a nice diagram of the uterus and the fallopian tubes. In theory, sperm is deposited in the vagina during intercourse, and it swims through the cervical mucus all the way up into the uterus, all the way into the fallopian tubes, encounters the egg, and then it's fertilized, and then it moves back down towards the uterus and implants, and that's how a baby grows in the uterus. So we need to know that this is working. There are about 3 tests that we do to look at the reproductive tract. And depending on which fertility clinic you go to, they may do 1 or maybe even all 3 of these testing. So let's talk about the reproductive tract. The first test we do is called the HSG, histosalpingogram. That's a dye test where we see if the fallopian tubes are open. We do this under X-ray guidance. So it's a speculum exam done in the clinic, speculum placed into the vagina, and we insert a catheter into the uterus. We then inject dye through that catheter. What we're looking to see is that the dye goes into the uterus, and then in theory, hopefully, goes into both fallopian tubes and spills from both fallopian tubes. That test tells us that the fallopian tubes are open and also gives us an idea as to generalized uterine contour. The second test is called a saline infusion sonogram, sometimes also called a sonohystogram or hysterosonogram. That is a vaginal ultrasound, but as we're doing the ultrasound, same thing, we're going to be injecting. So we can inject saline into the uterus and see the uterine cavity. And now I like to do this saline infusion sonogram using a 3-dimensional probe. That gives me a better idea as to the uterus, but I can see polyps. Polyps are benign, meaning non-cancerous growths within the uterus. The small ones don't really affect pregnancy. It's only as they get larger it's when it becomes more important. On the saline infusion sonogram, we can also see fibroids. Fibroids are benign, meaning non-cancerous growths in the uterus. In both the HSG and saline infusion sonogram, we can see scar tissue within the uterus. Sometimes you can have scar tissue within the uterus from previous surgical procedures, and we can see those very clearly on those 2 procedures. On both procedures, we can see things like Mullerian anomalies. So let's talk about what that means. Mullerian anomalies, when we were growing within our mother's tummy or within our mother's uterus, in those 9 months of gestation, all of our organs were being formed, including our uterus and fallopian tubes. So actually what happens is the uterus and fallopian tube starts off as 2 separate horns. The 2 horns meet and fuse, and in the middle part of that recanalizes or reabsorbs. And so it pops open like this, And that's how we get the cavity called the uterus, where an embryo would implant and grow. Well, there are multiple things that can go wrong during that time frame, either with the fusion or the recannulization, and that's called a Mullerian anomaly. And you could potentially detect those abnormalities on the HSG and saline infusion sonogram. Sometimes on the saline infusion sonogram, you can use saline. There are other types of contrast that are present today that you can inject at the time of the saline infusion sonogram that may be able to tell you if one or both tubes are open. Now, this takes a little bit of work and time to find these, but you can avoid doing the HSG if you had this special contrast. Keep in mind, these tests are a little bit more expensive because the special contrast costs more. So depending on what your doctor prefers, they may or may not do one or both testing. The third test that your doctor may do to look at the reproductive tract is a hysteroscopy. So that involves putting a small telescope called a hysteroscope into the uterus and looking for those abnormalities we just talked about. Now, the hysteroscopy can be done in the office, and that's usually a diagnostic hysteroscopy. It could also be done in a surgical procedure room under anesthesia, and that's an operative hysteroscopy where we can fix things like the polyps or the fibroids or the scar tissue. Now, all three tests, the HSG, the saline infusion sonogram, and the hysteroscopy, generally we like to do those testing somewhere between days 5 through 12 of your cycle. So ideally, after you're done bleeding, but before you get to ovulation day. Or if you're on birth control pills, it's a little bit easier as well in terms of scheduling those procedures. One of the biggest questions I get is, are these procedures painful? And these procedures do cause cramping. So I tell my patients, take Motrin, Advil, Tylenol, Aleve, something about a couple hours prior. Some patients, we may have to give a Valium or some type of pill that helps them relax some more prior to these procedures. Some offices offer nitrous oxide, which is a gas you would inhale that would make you more relaxed during these procedures. So yes, these procedures are a bit crampy, so take some pain medicine ahead of time. And many times as well, fertility clinics may have you take a course of antibiotics around the time you do these procedures, and that's just to prevent infections that may be associated with these procedures. Many people need treatment to have a child today. So there's nothing wrong with you for asking for help for your fertility. And there's no harm in doing testing and getting some answers. There's no shame in this. So there's nothing wrong with you. Do the testing, learn what your testing results are, and then find out what treatment options are available to you. Because if you look around, there are many other people just like you who cannot have a baby and will benefit from fertility treatment. So just remember, you're not alone in this. I'm here to answer your questions, and we will talk at the next episode.
Pioneer.